Now, the next topic we're going to talk about is now the drug's gotten into the systemic circulation and it's going to distribute into tissues. Right? So the drug has gotten there. And so how does it distribute and where does it move? It's moving across biological membranes, but its movement will depend on the physicochemical characteristic of the drug. Is it hydrophobic? Is it able to cross the membrane? Does it need a transporter? Is there something excluding it from a particular body area? Right, so the physicochemical nature of the compound, flow of blood, also whether or not a drug is bound to plasma protein. Remember, drugs can bind to plasma proteins. So if you were looking in your textbook, chapter 3, the first table that talks about bioavailability of all those drugs on the list, will talk to you about plasma protein binding. Does your drug have a high affinity for plasma protein or not? Some drugs don't really bind plasma protein that much. So they're free in the blood to move around. They can leave the blood and enter tissues. Some drugs are highly bound to plasma protein. So you cannot be in two places at once. If you're bound to plasma protein, you're not as free to enter a tissue and bind to a receptor. And if you're bound to plasma protein, you're bound. So only the free portion is what can diffuse into tissue. Right? So there are certain proteins in our blood called plasma proteins. One of them is albumin. Right? Another one is called alpha-1 acidic glycoprotein. And proteins like albumin bind acidic drugs. Basic drugs bind to alpha-1 acidic glycoprotein. So these things act as what your textbook calls inert binding sites. Right? So if you're on a plasma protein, you're not activating a receptor and causing some kind of signal transduction pathway to happen if you're bound to a plasma protein. You're sequestered from tissues and receptors and from doing that. Right? So being bound to plasma protein is pharmacokinetically relevant because usually proteins will distribute off of plasma protein in equilibrium, and the free fraction can enter tissues. Right? So only the unbound drug is thought to diffuse into tissue. If there are changes in the amount that are bound, the amount of drug bound to plasma protein might affect the activity of a particular dose. And there are certain things like a disease that may alter binding. So things like myocardial infarction, a GI disease called Crohn's disease, autoimmune disease like rheumatoid arthritis, liver disease, these can all impact plasma proteins. Remember, the major synthesizer of albumin and alpha-1 acidic glycoprotein is the liver. Right? So if you have liver disease, you may have altered plasma protein. Now, the big thing we shouldn't forget with plasma protein is a potential for a drug-drug interaction called a displacement reaction. A displacement reaction. So, if this is albumin, right, and it's floating around in the blood, and it's bound up a lot by drugs, let's call that drug warfarin. And let's say that 99.9% of a dose of warfarin is bound to plasma protein, and only a little bit is free to enter into tissues. And that's an anticoagulant drug. And normally, if that's the only drug they're taking, you don't really worry about the plasma protein binding per se. Only one drug. But now, let's say you bring along drug X, and drug X starts to displace some of the W's and take its place on the albumin. So what has happened to the three levels of warfarin in that situation? So patients taking warfarin, but now they're taking drug X. Drug X also wants to bind to the plasma protein. There's competition going on. So some of the warfarin gets displaced. But because it's displaced, it's now free, and because it's now free, it can do what? Have more of an effect than otherwise would say. Yes? So this is called a displacement reaction. And displacement reactions can occur when two drugs compete for binding to the same plasma protein. If you're only treating monotherapy, one drug, you don't worry that much. But if both drugs now compete for plasma protein binding, now you've got a situation where you can have okay? Now, some drugs, in terms of distributions, can become bound in tissue, in a particular tissue, and that tissue becomes a depot, right? You've heard of the Home Depot. What do you get at the Home Depot? What kind of stuff? Hardware. All things hardware, right? Nails, screwdrivers, whatever, right? Well, a tissue depot or a tissue reservoir is a place where a drug can accumulate. So there are certain areas in the body that may accumulate drugs. For example, fat. There's some drugs that may accumulate in fat. There's some drugs that can accumulate in the bone. Right? So the bone can be a tissue reservoir for certain drugs. So when it comes to distribution, we're talking about where is the drug, right? Where on earth is Carmen Santiago, right? Where in the body is the drug? And so the reason, or maybe one way to think about this, is when we administer a drug into a central compartment, that being the systemic circulation, the drug is going to distribute into a target or peripheral tissue. It's down a concentration gradient, right? So you're going to give a high concentration into a compartment like the systemic circulation, and it's going to start to go down its concentration gradient into areas where it can. Right? Where can it go? It's kind of like when it rains, right? And the water hits the roof of your house, and where does it go? Right? It goes down certain places, right? It goes down the flow of gravity, so it goes down the side of the roof. It goes down the gutters. It might flow down a hill, right? The drug's going to go where it can go. That's called distribution. Where is it going? And notice that in the body, already, we have this other point of exit called elimination, right? So distribution and elimination are happening at the same time. So one of the parameters regarding distribution that's critical to understand is called the volume of distribution. And the volume of distribution is another one of these big pillars in the chapter on pharmacokinetics. So we've said bioavailability, we've said plasma protein binding, now we're saying volume of distribution. And what that does is it relates the amount of drug in the body to the concentration of drug in the blood, or in some cases in the plasma. And so the equation for volume of distribution is the amount of drug in the body divided by the concentration in the blood. And so remember when you come to this model of an animal, right here, let's say it's Tom, right? So Tom has taken a drug. And how do you know where it went, where it distributed? Well, there's really no easy way to know. There's no scanner where you can see, 1 milligram is in the kneecap, and half a milligram is in the coat. And you can't really tell. There's really only two fluids that you can easily measure: blood and urine. Right? And so volume of distribution says, well, what's the amount of drug in the body compared to what I've measured in the blood? Remember, if the drug's to function, it's going to have to leave the blood and enter the tissue. Right? So if I administer 10 milligrams into the blood, and all 10 milligrams is in the blood, has it distributed? No. But if I administer 10 milligrams of a drug, and a few minutes later I measure it in the blood, and there's only 1 milligram, there's nothing in the urine yet, then where did it go? 9 milligrams went somewhere. Right? It went into the body, went into the tissue. So the volume of distribution is the amount of drug in the body divided by the concentration in the blood. Some books will divide by the concentration in the plasma, right? Because the plasma is the non-cellular component of the blood, right? It's the blood without white blood cells. So our book, I think, uses blood as the base. Maybe a future class will look at plasma as the denominator. So what's the difference between blood and plasma? Plasma is the protein and the liquid part, right? So one thing to note is that this is really just a ratio. How much of drug is in the body by how much is in the blood. We call this an apparent measure. It's a theoretical value. And as that last bullet tells you, the volume of distribution can greatly exceed the actual volume of a biological system. So let me try to show you. So let's say you administer a drug into the body, and some time goes by and you measure a blood sample. Okay? And let's say the volume into which you've distributed the drug is where the drug has entered and dissolved, but you're only measuring a tiny part called the blood. Right? So let's imagine that you've administered a dose of 5 milligrams, and that a blood sample reveals a concentration of 1 milligram per liter. Then the volume of distribution must be 5 liters, since VD is the dose divided by the concentration. Right? So the dose is 5 milligrams. The concentration that you've measured is 1 milligram per liter. So the volume of distribution is 5 liters. Yes? Okay. That's a simple example. And so if you were to look at the volume of distribution for various drugs, what you'll see is that as the number increases, it means that more of the drug has left the blood than is in the blood. Right? So what does it mean if the volume of distribution exceeds the actual volume of the blood? Where is the drug? It's in the tissues. Okay? So if the volume of distribution is large, how would you interpret that? Well, remember, it's the amount of drug administered divided by the concentration in the blood. So the larger the number, the larger the volume. The larger the number means less in the blood and more in the tissues. Right? Less in the blood and more in the tissues. So if you were to compare these drugs to each other, which of them is more likely to be found in the blood compared to the tissues? Chlordiazepoxide or propranolol? Remember, the larger the number means distributes out of the blood. Right? So the one most likely to be found in the blood would be the one with the lowest volume of distribution compared to the others. Okay, so the summary on volume of distribution tells you about how likely or the degree to which a drug has left the blood and entered tissues. We examine a piece of the body, the blood, and we use it to tell us if the drug is well distributed. And lastly, it's apparent measure, because some drugs, as you may see in your textbook, have volumes of distribution that are like 10,000 liters. So, okay, 1 liter of water weighs how much? 1 liter of water weighs how much? 1 kilogram. Right? I weigh about 110 kilograms. That's my body weight, 110 kilograms. So what's my body volume? Approximately 110 liters. Right? So if a drug has a volume of distribution that's 10,000 liters, I mean, even the biggest person that I've ever seen in my life would never be 10,000 liters, right? Maybe 300 kilograms, maybe it's max, 300 liters, right? So this is a theoretical number. It just tells you the tendency of the drug to distribute out of the blood into tissue. It doesn't really tell you the true volume of your patient. It just tells you what's the tendency of the drug to actually distribute. So if I have to give a drug that distributes into the body and, let's say, acts in the brain, and do I want to give a drug that has a high volume of distribution or a low volume of distribution? A high volume of distribution. I want to be able to distribute into the body. So if the volume of distribution is large, distribution is great. If the volume of distribution is small, distribution is limited. So what do you think about a drug that, for example, is mainly designed to act in the blood? Do you think it's going to have a high volume of distribution, or if it's mainly designed to act in the blood, it's It's mostly going to be in the blood and going to have a low volume distribution. Right? So can you name a drug that I just talked about that is a drug that's meant to act in the blood? Starts with W. Warfarin. Right? It's an anticoagulant drug. It doesn't have to get into the tissues, and it doesn't have to get into the fat, and it doesn't have to get into the bone. Yes? Okay. Okay, so when it comes to distribution in the central nervous system, there are barriers that restrict flow into the central nervous system, which is probably a good thing, because if certain compounds could access your brain that would be toxic to your brain, you wouldn't be you, right? So for example, in chronic alcoholics, what's one of the toxicities associated with chronic alcoholism? Neurotoxicity. Right? The brain is damaged because alcohol can access the brain, can injure the brain chronically. Right? So there's certain types of CNS toxicities that are seen in advanced stage alcoholics. So the fact that there's a barrier is probably a good thing. It protects you from toxicity, who you are. The brain capillaries have this blood-brain barrier, unique tight junctions of the endothelial layer that prevent most things from getting through. And so overall, the things that do access are generally non-ionized and lipid-soluble. All right, so if you look at some of these anti-anxiety drugs or these anti-depression drugs, right, these are unionized drugs that are able to cross the blood-brain barrier and enter. Right, so things like diazepam or alprazolam, Xanax, those things are able to cross the blood-brain barrier and have action in the brain. They're able to distribute into the brain. Interestingly, when you have brain injury and inflammation, the blood-brain barrier gets compromised. Right, so there's a huge discussion now in the NFL about brain injury due to repetitive concussion. Right, you may have heard of, there's a very famous player whose name I don't know, retired after 1 year because he kept getting concussions, and he said, it's not worth it. I don't want to have brain damage when I'm older. I don't want to be debilitated when I'm 25 years old. Football. Right? So one of the problems with the concussion and the inflammation, there's all kinds of problems. The blood-brain barrier can become compromised and then allow access of things that shouldn't get in there. Right? So if brain cells start to die kind of haphazardly due to toxicant exposure or drugs getting in that shouldn't, your personality changes and you're not you anymore.
Looking at the blood-brain barrier, we have a special type of barrier across which only certain types of drugs will be able to move. So if you look here on the left, what you see in the middle is a blood vessel lined by endothelial cells, and those endothelial cells, if you can see, the arrows are pointing to the endothelial. Well, one of the arrows is pointing to an endothelial cell, another arrow is pointing to the tight junction. And as you can see in this area, the endothelial cells form a very tight, impermeable layer, unlike a typical blood vessel that you see over here on the right, where there are some spaces between endothelial cells, small spaces called fenestra, that can allow for passage of certain small molecules through those intracellular spaces. Right, but you don't see that over there on the left. The fenestra are not there because of specialized tight junctions that we see in the brain and in the spinal cord, in blood vessels that perfuse those areas. So the kinds of drugs, therefore, that can enter an exchange between the blood and the brain are going to either be lipid-soluble drugs or drugs that have special transporters that are going to allow passage across that barrier. And so while it's not a drug, the molecule glucose, which we've used a couple times as an example, is able to enter the brain, not because it's hydrophobic. On the contrary, it's tremendously hydrophilic, but it will pass in through a transport protein called the glucose transporter. And so there are many different types of glucose transporters, and you'll learn about some of them in when you get to diabetes and the relevance of insulin and how insulin works. But in the brain, all brain cells have what we call a basal glucose transporter that's going to let sugar in. So, not to go beyond the point here is that when you have specialized barriers, there can be drug exclusion, and so this is why we talked about routes of administration that can kind of circumvent the blood-brain barrier, for example, intrathecal, but they require careful precision and deposition of the drug into the CNS directly. Okay, so again, the blood-brain barrier is one area where we see this type of endothelial cells forming tight junctions. The blood-testis barrier is another in males. Okay. In terms of distribution, I wanted to spend a moment talking about the placenta and the pregnant female. If you look here on the right, you see a diagram sketch of this tissue we call the placenta. And really, if we look at the placenta, we see it's really a kind of a meeting of blood, right? The maternal blood and the blood of the developing baby are kind of meeting here. And the placenta is going to allow exchange of good nutrients and things that the developing baby needs to obtain from the mother. And as you can see at the very bottom of the diagram, you see the umbilical arteries, the umbilical veins, which make up the umbilical cord, right? So when they say you cut the umbilical cord, right, you're cutting off the connection to the placenta, right? And so if you look at this placenta, you see it's a highly perfused tissue. Many drugs will be able to transfer across the placenta, but things like lipid solubility, degree of ionization, degree of plasma protein binding are all going to play a role on whether or not a drug can cross the placenta. So obviously if a drug is category X, it's going to be able to cross the placenta and potentially cause birth defects. Right, so an example of a drug that we've talked about that can do that was thalidomide. But there are many examples of category X drugs. So we mention the placenta here as a special consideration because it also can act as a barrier and protect the developing baby. But in many cases, drugs can distribute across the cells of the placenta and enter into into the developing baby. This graph is an example of that. If you were to look here at the y-axis of the graph, the y-axis measuring the concentration of a drug called lidocaine in the blood, and the x-axis is looking at time. And this is an experiment where lidocaine was administered to the mom. And as you can see, at time 0, the level of lidocaine in the maternal artery was very high compared to the level of lidocaine in the umbilical artery, if you look down at time 0. But then what we see is, as the lidocaine starts to distribute from the blood into tissues, one of the tissues it's distributing across is the placenta, as you can see in those bottom two curves. And so you can measure drug both in the umbilical artery and then in the umbilical vein. And then that second portion of the curve is the elimination phase, right? So lidocaine is a drug. It's used for several different kinds of things, but it's one of the common anesthetics used in dental procedures. So if mom's having dental work done, the drug can cross. Now, lidocaine is a category B drug, and again, the idea there is, to try to avoid its need if it can be avoided. Not all dental procedures will require administration of lidocaine, as we know. But again, this is an illustration of this concept that drug that's administered to mom can end up crossing the placenta. So when we look at blood as a marker of the drug being absorbed, what we usually see is that following administration of the drug, down here on this graph down at the bottom at time 0 indicated by that syringe, at first the drug will be in high concentration in the blood, but if you were to continue monitoring it over time, you'd see that there'd be an exponential drop. And here that graph comes to kind of a flat plateau, right? An exponential drop to a flat plateau, which is an artificial kind of environment, because in reality, following distribution is elimination, right? Here, the graph is drawn to not show you elimination, it just shows you the distribution phase of the drug after administration. I believe the next slide we'll see also the elimination phase. And so while this is kind of an artificial drawing to kind of show you the process of distribution of drug from blood into tissues, this graph is showing you what typically happens. So as the drug is administered, it begins to distribute, and then it begins to exhibit a slower exponential decline, which we call the elimination phase. And again, if there's no second administration of drug, eventually the drug will be completely eliminated. The next topic in our chapter is that of clearance. And clearance is the ratio of the rate of elimination by all possible routes. So whether it's through the liver into the bile, whether it's through the kidney into the urine, and so on. Okay, it's going to be the ratio of the rate of elimination through that site to the concentration of the drug in the blood. Right? So if you look down here at the box on the bottom right, you see clearance through the kidney will be the rate of elimination in the kidney divided by the concentration of drug in the blood. Same equation is useful in the liver or in other sites. For example, if a drug is sweated out, you're physically active, you're running, you're sweating. In some cases, perhaps a drug is eliminated in part through sweat. Okay, so that would be the other subscript. And so to really kind of get a gauge on systemic clearance, it's really the sum of all routes, right? So whether it's cleared through the kidney, the liver, or other routes. And so if you were then to just want to know the rate of elimination, you can solve this equation. It'll be the clearance times the concentration of the drug. The clearance will generally remain constant for a drug, and so if you look in chapter 3 of your book, you'll see that one of the columns refers to the clearance of various drugs, and most drugs that's a constant, and what will vary is the rate of elimination. So again, clearance as a concept is the rate of elimination divided by the concentration of drug in the blood. And another way to look at it is as the rate of drug removal that's divided by the concentration. If we kind of think about that for a moment, the rate of removal of drug will be an amount per unit time, right? Because we're talking about a rate. So, for example, milligrams per minute or grams per hour, right? It's an amount of drug being removed per unit time. Concentration is going to be an amount of drug per unit of volume, right? How much blood is, what's the concentration of drug in the volume of the blood? So, milligrams per milliliter, right? Or milligrams per deciliter, or grams per liter, or whatever the unit may be, but an amount divided by a volume would be concentration. So if you then solve for clearance as rate of elimination, an amount per minute, right, milligrams per minute, and divide by an amount per volume, mgs per mil, what you end up with is a volume per unit time, depicted there in the white font, milliliters per minute. So one way to think of clearance is as the volume of fluid, here we're talking about blood, that would need to be completely freed of all drug to account for the elimination. Right? So it's the amount of volume, it's the volume cleared of drug per unit time. So when you look at clearance in chapter 3 of your book, it's going to be, milliliters per minute or liters per hour. What does that refer to? The amount of blood cleared of drug per unit time. A simple example of clearance is described for us here. Take a simple rat that's got about 10 milliliters of blood pumping through it. And suppose that you administer into that 10 milliliters of blood a 100 milligram dose. 100 milligrams divided by 10 milliliters comes out to 10 milligrams per milliliter at the time of administration. Right, assuming that it all went in and it was all soluble. 10 milligrams per milliliter at time 0. And so now, 5 minutes later, blood sample reveals that the concentration of drug in the blood is 5 milligrams per milliliter. So 5 milligrams times 10 milliliters of blood means there's 50 milligrams. So 50 milligrams has been removed. So in order for the rat to eliminate the 50 milligrams of drug, and let's say again that the original concentration was 10 mg per milliliter, well, then it must have cleared drug from 5 milliliters of blood between those 5 minutes. Right? Because the rat got rid of 50 mgs, and it's 10 mgs per mil, so it must have cleared 5 milliliters. So since the original concentration was 10 mgs per mil, what is the clearance of the drug? Well, clearance is going to be 10 mgs per min divided by 10 mgs per mil. Right? 10 mgs per minute divided by a concentration of 10 mgs per mil. Why 10 mgs per minute? Because 5 minutes have gone by and we've cleared 50 milligrams. Right? So per minute, 10 mgs per minute. Why 10 mgs per mil? Because 10 mgs per mil is what we had concentration in the blood at the starting time. So if you now solve for clearance, the clearance comes out to be 1 milliliter of blood cleared of drug per minute. 1 milliliter of blood cleared of drug per minute. Example of clearance. So again, clearance will be in units of volume per unit time. And you'll see examples of clearance in your textbook if you look at table 3-1. For most drugs, it's important to remember that clearance is constant almost over all ranges of blood concentrations. So clearance tells us a lot about how a drug is eliminated. And in addition, the volume of blood cleared per unit time is usually independent of the concentration. Usually as the concentration of a drug increases, the rate of elimination will also increase, but the clearance generally stays constant. Now, that's usually what happens, right? So as the blood flows to the tissue, the drug continues to be cleared. It's called flow-dependent elimination. On the other hand, for some drugs at high concentrations, the process of elimination becomes saturated. And this is going to now be called capacity-limited elimination. And that's going to be true of things like ethanol, for example. In an example where you see capacity-limited elimination, the rate of elimination is independent of the concentration, and the clearance falls. It takes longer to get rid of the drug. Alright, so these are called saturable, dose-dependent or concentration-dependent, non-linear in terms of Michaelis-Menten kinetics or elimination. And I've shown you some graphs of this as well in the homework lecture. In capacity-limited kinetics, a constant amount of drug is eliminated per unit time. Constant amount of drug, rather than a constant fraction of drug that's eliminated per unit time when we have flow-dependent elimination, also known as first-order kinetics. So when it comes to drugs that exhibit capacity-limited elimination, these are saturable, and the steady-state concentrations are not achieved in the way that we see them for drugs that undergo typical clearance and exhibit first-order elimination kinetics. So we've spent some time talking about volume and distribution, we've spent some time talking about clearance. And the reason for this is that for drugs that exhibit first-order elimination kinetics, which is most drugs, unless you're ethanol or phenytoin or a few other drugs, but most drugs that exhibit first-order elimination kinetics will exhibit something called the elimination half-life. How long does it take for the body to eliminate 50% of the drug? That's called the T1/2, the elimination half-life. And what we see here is that half-life is directly proportional to the volume of distribution and inversely proportional to the clearance. As if a drug is quickly cleared, it has a short half-life. If something affects the clearance such that the clearance is now slower than it otherwise was, the half-life is longer. And half-life is a useful concept in pharmacokinetics for a reason I'll discuss in a moment. So half-life is directly proportional to volume of distribution, inversely proportional to clearance, and this conversion factor 0.693, it's a constant. So half-life is equal to 0.7 or so times the volume of distribution, or 0.693 times the volume of distribution, and inversely proportional to the clearance. The half-life is the time interval after which the concentration is half that at the beginning of the time interval. It's constant throughout the dosing interval and has real meaning only in first-order kinetics. So for example, you administer a certain dose of a drug. One half-life is the time it takes for that dose or that concentration in the body to reduce by 50%. And so one half-life you go from 100% to 50%. In the second half-life you reduce where you are by 50%. So you fall to 25%. In the third half-life you reduce where you are by 50%. So you fall to 12.5%. In the fourth half-life you reduce where you are by 50%. You go down to 6.25%. And so on. So half-life is the amount of time it takes to reduce the dose by 50%. Has meaning in first-order kinetics, which most drugs happen to fall into, but not all. The half-life is useful in estimating the time to the steady state. And so what is the steady state? I'll show you that in a moment. Approximately 4 half-lives will be required to reach about 94% of the steady state. And so the half-life is useful in estimating the time needed for drug removal from the body, and it allows us to estimate the appropriate dosing interval for a drug. So what does this look like? If you look at this graph, the y-axis is the concentration of a drug called phenytoin. The x-axis is time. And what you can see here is that in order for the drug to reach an average concentration that's indicated by the linear curve, the curvilinear section, right? You see there's like a curve that's running through these peaks and valleys, right? An average concentration. That would be the average concentration. And you see peaks and valleys on this graph. And so the reason for this is that it really takes about 4 half-lives if you follow, right? If you follow, it takes about 4 half-lives for this drug to hit the steady state. So that's almost a week. Right, so what do you mean by half-life? Well, see, in the first dose I went from 0 to 6. And then I started falling. And then I gave a second dose, and I went from, let's say, 3 up to about 10. And then the body started eliminating it, and I fell from 10 down to about 6. I took another dose, and then the drug started to be eliminated. Took another dose, and the drug started to be eliminated. It took me about 4 half-lives of dosing to reach a situation where the dose that's eliminated is replaced in the next dose. The dose that's eliminated is replaced in the next dose. The dose that's eliminated is replaced in the next dose. So that's called the steady state. When you've gotten to the steady state, you've bracketed the target concentration of a drug, and that's going to be the concentration of drug that's effective. Right? So if you look in Chapter 3, Table 1, the concentration of drug that's effective is going to be dependent on the drug, but in order for the drug to be effective, it's got to be at its target concentration, and that will have been determined experimentally, right, in clinical trials. But in order to get to the target concentration, usually takes about 4 half-lives to get there. And so one way to kind of circumvent this is to give a loading dose of a drug. And what a loading dose is an extra large first dose. So it puts you right into the therapeutic, the target concentration, right? The therapeutic concentration. So if you look at this graph, the target window for therapeutic effect is the shaded gray area. And so if you were to not give a loading dose, it would take about 4 half-lives to get up to the steady state, which is now going to bracket the target concentration. But sometimes you might not have the luxury to wait 4 half-lives, 4 or 5. That you may hear different numbers from different professors, right? 4 or 5 half-lives, but generally 4 to 5 half-lives on, 4 to 5 half-lives off out of the steady state. And so here you go. Emergency situation. Got to get the drug into that gray shaded area. Patient's unconscious. Patient's dying. Patient's in cardiac arrest. Whatever the case may be. That first dose is going to be an extra large initial dose to get the patient at the steady state. That's what a loading dose is. And so some of you may be familiar with this if you ever had a Z-Pak. The first time you take the Z-Pak, you take 2 tablets. That's a loading dose, and then the subsequent treatments are 1 tablet, getting you into the therapeutic range of the drug. So I encourage you to look at Chapter 3, Table 1, and look at the target concentration for various drugs, just to see that they're not all the same, and they're obviously going to be determined experimentally. Sometimes those target concentrations will be nanograms per milliliter, sometimes they'll be milligrams per milliliter, sometimes they'll be milligrams per liter. Okay, so it's not that the target concentration is the same for every drug, but if you don't reach the target concentration, the drug won't be effective. And if you overshoot the target concentration, you're going to start to increase likelihood of toxicity. So the formula for calculating loading dose involves knowing the bioavailability, knowing the target concentration, and knowing the volume of distribution. So the loading dose is equal to the target concentration times the volume of distribution divided by bioavailability as a fraction. So if the drug is administered IV, then F is 1. Right? But if the drug is administered by some other route, F might be less than 1, and we need to pay attention to that. So all of the parameters in this equation will be known based on experimental data. And you have, for example, in Table 3-1, all 3 of these variables for particular drugs: the target concentration, the volume of distribution, the oral bioavailability. And so loading doses are calculated like this. So let's do a simple example. So let's say you wish to achieve an immediate blood concentration 50 micrograms per liter of a particular drug, and that the volume of distribution is 200 liters for that drug, and that the route the drug will be administered is intravenous. And so you just plug in all your appropriate numbers. You come up with 10,000 micrograms as a loading dose. And it's much easier to work in milligrams, so we convert, right? 1 milligram is 1,000 micrograms. So 10,000 micrograms is 10 milligrams. Simple example of a loading dose. The last topic of Chapter 3 involves calculating a maintenance dose. Now, maintenance dose is the dose needed to replace what was lost in the interval immediately preceding the next administration of the drug. Right, so if a patient's taking a drug twice a day, the maintenance dose, the purpose of that is to replace what was lost in the past 12 hours. So the person took a drug, 12 hours went by, right? We've lost some of that drug due to elimination, so let's replace what we've lost so that we can keep the target concentration in the steady state. And so, how does one calculate maintenance dose? Well, here's an example from our book where we're looking at a drug called theophylline. And in order for theophylline to be effective against asthma, its target plasma concentration is 10 mg per liter. And we look up the clearance of theophylline, and it's listed in our table in Chapter 3 as 2.8 liters per hour per kilogram. And since the drug will be given as an IV infusion, our fraction is 1, bioavailability 100%. So here we'll calculate the dosing rate. Clearance times the target concentration divided by the fraction that's absorbed. Here, that is 1, because it's given IV. So when we calculate the dosing rate, that comes out to be 28 milligrams per hour in the 70 kilogram patient. Why? We're putting the body mass there because not everyone weighs 70 kilograms. Some people will weigh less, some people weigh more, so that's a normalization factor. So here's the proper infusion rate for IV, 28 milligrams per hour per 70 kilograms. And so if that asthma attack has now been relieved, the acute emergency has gone by, the clinician might want to maintain the plasma level with oral administration of theophylline, maybe twice a day. And when we look up the bioavailability of oral theophylline, we see it's very high, 0.96. It's pretty close to IV, really, which is, not always typical for drugs administered orally, but in this case, it is. And so the maintenance dose is defined as the dosing rate, which we just solved, divided by the bioavailability, times the dosing interval, the amount of time that has gone by. So during that interval we've lost some drug and we're starting to fall out of the steady state. So let's give back enough drug to put us back into the steady state. So let's turn the valley into a peak. And then over the next 12 hours it'll become a valley again and a peak and a valley and a peak. And the idea is to keep those peaks and valleys in the target concentration range without letting it fall below, without letting it crawl above, to either prevent loss of efficacy or increase likelihood of toxicity. So here when we solve for maintenance dose, we plug in our dosing rate, our bioavailability. The doctor is giving the drug every 12 hours or twice a day, so we plug in the interval, so the time units cancel out, and we end up with a dose, maintenance dose of 350 milligrams twice a day by mouth. Okay, so as you kind of go through the chapter, give yourself some time to internalize some of the concepts that we've been discussing here. Things like volume of distribution, things like clearance, things like half-life, things like bioavailability. Okay, and become familiar with the equations for things like half-life and clearance, dosing rate, maintenance dose, loading dose. So there's a handful of equations that you should feel comfortable understanding, you know, as a consequence of going through this material, and which later courses will build upon as they talk to you more about clinical pharmacokinetics. So with that, we're going to wrap up Chapter 3. Again, you have a review sheet for Chapter 3. This is Lecture 5. You have a homework lecture that recapitulates some of these things, maybe adds some new information that will help you answer some of the questions on the homework sheet. I've even posted some short tutorials on pharmacokinetics that I've watched and found to be factually accurate. And so again, there's no surprises here. The information that you're seeing is information found in the book, right? So the information in Chapter 3, and it's spread across a few formats in this chapter. We had the in-class lecture. We had what was left over from the in-class lecture, which is this, the homework lecture, and then some tutorial lectures. If you learn well from listening or watching these kinds of things, that will be useful to you. Otherwise, work through the review sheet and use your book and use your slides and put that information in your mind. And you'll also be well prepared for what's coming in future courses and you know, in our course on quizzes, exams, etc. So I wish you well, and we will continue our discussion the next time we meet.